Hello, good afternoon, and welcome back after a Christmas break. I hope you all had a lovely Christmas and New Year given the COVID circumstances. We're going to start off today with the paediatric neonatology case exchange, and I'd like to introduce Sabina as our first SHO speaker, followed by Sujo Francis, a neonatal consultant, and then Sarah has got the wonderful MCQ quiz. So without further ado, I will hand over to Sabina for her presentation. Do you want me to run it, or would you rather? You. Okay.
Could you please, Emma?
That's fine, it's not a problem. Here we go. Just tell me when to change slides, okay?
Okay, dokie. All good. Can everyone see the slides? Oh, do I have to swipe? Yeah, fine. Okay, go for it. So hi everyone. Welcome to the new year. My name is Sabina. I'm a paediatric trainee in South London. So I'm going to talk to you about neonates. Next slide, please. A familiar call to those of you who've done tertiary NICU. It's about 3 AM. You're bleeped by a nurse to review a baby in HDU. It just say he's tachycardic. Can you please come see the baby? And then they ask for further details. They say, I'm really sorry, I don't know the baby. My colleague's gone on break and she's asked me to get you to see them. Next slide, please. So you head off down to HDU and this is what you come across. So this is baby R, who's a X28+3, now corrected gestation 33+5. Had a birth weight of just over 1 kilo. Currently, baby is self-ventilating in air. They're on full enteral feeds of 150 of MEBM, so that's mum's milk, and half breast milk fortifier, getting that 2 hourly via the nasogastric tube. Trialing a few bottles a day, but not quite made it onto full bottle feeds yet. Medication-wise, they're just on a bit of Citron. You get a little bit more information. They say not vomiting, no fevers, but been a little bit quiet today and done a few fleeting desats, but currently still self-ventilating in air. Next slide, please. Examining the child, you notice the observation. So the heart rate is currently sitting about 184, but it's been ranging for the last couple of hours between 165 to 190. Temperature 36.6, respirate of 65, and SATs are 94% in air currently. Baby is asleep, but rousable. Bit cool on the peripheries, a little bit mottled. The cap refill was about 4 seconds peripherally, but normal centrally. Soft anterior fontanelle, heart sounds are normal. Good air entry on the chest, a tiny bit of subcostal recession, but you think that's mainly related to this distended abdomen that you notice. It's a little bit red, bit tender when you press on it, and the bowel sounds are a bit quiet. Next slide, please. What are you thinking? I would love some input. If you don't want to speak, then please do feel free to use the chat. What have you noticed about those observations in that examination? And what are your differentials you're thinking of? Anyone at all? Don't mind if it's consultants' input too. I'll give it another minute or so, just in case people are typing. Okay, are we feeling shy? Yes. Well, thanks, Nicholas. Yes. So next slide, please, Emma. Next slide. Oh, so as you may have noticed, the baby is tachycardic without a fever. They are mottled. They've got a delayed capillary refill. And they are an unwell neonate. So I just find it helps when I'm examining a baby just to think in my head, are they sick, are they not? Just because it gives me a sense of urgency and what do I need to do about this. Differentials, obviously, distended abdomen, is thinking something like NEC or necrotizing enterocolitis. Sepsis, perforation, bowel obstruction are your kind of other possibles. Next slide, please. And Nicholas and anyone else who wants to get involved, what would be your cute management for this child? Anything at all. If you don't want to speak, just pop it in the chat. Yay! Excellent. Anything else you'd like to do? For example, if they didn't have a cannula? Yeah, all excellent suggestions, guys. Yep, perfect. Next slide, please, Emma. Knowing your luck, it won't be. We'll see. So yeah, you need your IV access, you need to get your gas, venous or capillary, get your bloods. I'd probably do a full panel on this baby, including blood cultures. You don't yet know really what you're dealing with, but yeah, you're right, thinking abdomen. IV antibiotics, as per your guideline. Think about, are you going down the sepsis route? Are you going down the triple antibiotics for abdominal source? Personally, I'd say the latter, but depends on what you think. Nil by mouth, NG tube. Do you need to think about fluid boluses? Do they need regular maintenance? Abdominal X-ray. If you're a junior, get your seniors involved, get a surgical review. And to be honest, in this case, I'd probably move them further down the corridor to ITU. Next slide, please. So I'm going to talk to you about necrotizing enterocolitis, or NEC as it's known. Next slide, please. So it's the most common intestinal emergency. Occurs as a varying range, but somewhere between 1% and 8% of NICU admissions. To be honest, 8% sounds like a huge amount, but we do see it. Most of the babies are premature, especially if their birth weight's less than 150 grams. But about 10% can be term. So don't rule it out in a term baby, but they often have risk factors. These include things like congenital heart disease, congenital malformations, especially gut ones, gastroschisis, Hirschsprungs. If they've had a prolonged course of neonatal hypoxemia for whatever reason, difficulties around birth, if they had lots of episodes of being hyperglycemic. And the reason we care so much about NEC is because it can have somewhere between 20 to 50% mortality, particularly if severe. Next slide, please. So I just thought I'd go a little bit more into the pathogenesis, the reasons why NEC occurs. Particularly with prematurity, there's a slightly more thought about what's going on here. So the idea is that there's this kind of leaky gut where bacteria can get in more easily, where the digestion and the absorption doesn't occur as well as it should do, and therefore the baby doesn't get their nutrients that they need in prematurity. And that leads them to kind of, also related to this, they have an immature immune system. So reduced certain immunoglobulins and defensins. They have reduced toll-like receptors. So these are types that are used to recognize pathogens and as part of your innate immune system. And you can get upregulation of the pro-inflammatory cytokines and other toll-like receptors, leading to, well, a whole load of problems with the immune system, basically. Reduced intestinal motility as well, and problems with regulation of blood flow. That includes the gut. Next slide, please. So your signs. So even if the initial damage is occurring in the kind of initial resuscitation, you normally only see the problems once you start introducing enteral feeds. So obviously for NEC, the major signs are distended abdomen. It can be red, it can be discolored, even blue at certain points, tense and tender. Doesn't have to be tender always, but often as you get further down the line, it is. They can have feed intolerance, including vomiting or large aspirates. They can even get rectal bleeding, diarrhea. Next slide, please. They get the signs of infection that we expect, so things like lethargy, tachycardia, temperature instability, reduced capillary refill or mottling. They can get desaturations, respiratory failure with this as well. And as the disease progresses, although hopefully you've caught it before this point, you can have bilious vomits, apneas, bradycardias, DIC, disseminated intravascular coagulation, and shock. Next slide, please. So in case you didn't know what a distended abdomen looks like, here's a not so pretty picture of one, please. And I apologize if anyone's eating their lunch. For the next slide, please. You do not want to end up like this. You've missed the boat in this case. You can see it's really distended, very tense. It goes shiny. You get these red patches of discoloration, and you can even see the blue patches of discoloration. Next slide, please. So your investigations, you're going to do your blood gas, whether that's a venous or capillary, doesn't matter. You worry about acute acidosis. It's a bad prognostic sign for NEC and the outcomes. It can be metabolic, it can be respiratory. You also worry about your raised lactate, which is a sign of poor perfusion. On your bloods, you can get the thrombocytopenia or signs of DIC. The white cells can go up, but they can go down as well, and you can get a neutropenia. And imaging, as you all mentioned earlier, abdominal X-rays, absolutely. Next slide, please. So in severity order, your abdominal X-ray findings. Oh, sorry, they've gone away again. Thank you, Emma. Abdominal X-ray findings, so non-specific bowel dilatation is what we see most commonly. Then you start to get thickening of the bowel wall. You can have fixed dilated bowel loop. It's got to be unchanged, obviously, on more than one radiograph. Pneumatosis, so these are small gas bubbles in the bowel wall and almost always associated with dilated bowel loops. You can get gas in the portal venous system, and worst case scenario, you're getting free intraperitoneal gas, which is your perforation. So now some more pretty pictures on the next slide, please. Your abdominal X-ray. So this was just trying to show pneumatosis. It's really quite hard to do on both Google Images and PowerPoint. But basically you get this kind of fuzziness, which is the pneumatosis I was talking about earlier. Next slide, please. And the idea behind this is, so this is a cross section of your gut. You get this inflamed wall with the gas bubbles, and that's the kind of pneumatosis you see in the previous abdominal X-ray. Next slide, please. So this is just to show free air under the diaphragm. You can see where the arrows are pointing. Next slide, please. So management, as we mentioned earlier, you get your IV access, you get your gas, send off your bloods, including a blood culture, because this can be also a picture of septic ileus as well. Your IV antibiotics as per your local protocol. Make them nil by mouth, get that NG tube down, start the regular maintenance fluids, boluses if they need it, if they're shut down, abdominal X-ray, senior review, and get a surgical review. And if they're in the special care end, you need to think about moving them to the ITU end so they can be more closely monitored. Thank you. Next slide, please. So just in summary, please don't ignore tachycardia. This baby had been tachycardic for a while, and yeah, they needed a review, especially tachycardia with no obvious cause. So this baby was not pyrexial, they weren't having kind of respiratory difficulties. We didn't have a reason for this tachycardia. Keep your differentials in mind when you're examining them. If you've got a baby that's tachycardic, if they're febrile, you've got to think about your source. Where's your source coming from? And I always find it helpful when examining a child to think in my head, is this child unwell or not? If they are unwell, I need to involve my seniors early. We need to get plans in place and let people know that this child is sick and they need further input. Next slide, please. Thank you very much for listening. Pleasure talking to you all.
Thank you very much, Sabina. That was fantastic. Let me just go back to main screen. Right. So just as the next session of case exchange will be under the topic of neurology, pediatric neurology, and if any SHOs would like an opportunity to present cases in the coming future, please do get in touch. Both Sarah and I are on the LSP website, but you also can email us directly on nhs.net. And I'd like to hand over now to CJ Francis, the consultant neonatologist at St George's.
Thanks, Emma. Can you guys hear me? I've got a bit of a problem and having to use multiple devices.
Yeah, I can hear you.
Yes.
Excellent. Unfortunately, you won't get any video, but that's probably not any loss. So hopefully you can see my screen now. Can you see some slides?
Screen. No.
Can you see a screen now? It says on my site that it is sharing my screen. Nope.
I'm going to make you presenter in the hope that that helps, because I can't see it.
Okay, yeah, I've got that now. Let's see, let's try that again. Oh, no, I've got a message that says you are no longer the presenter. Emma, I've sent it by email to you.
Okay, I will get it up.
Okay. While Emma's getting that up, the slides are probably not hugely important because it's just a framework for us to have a chat about this rather than me talking to you about loads and loads of things. It's going to work best if you guys are involved, so feel free to either talk or chat. I can see the chats coming up on the screen. So I've tried to sort of approach managing a sick neonate in a very sort of alphabetical fashion using the tried and trusted ABC kind of methodology. So if we talk about the airways, if you've got that child that Sabina was looking after earlier who was tachycardic, NEC, etc., from an airway perspective, what do you think might happen that might require intervention? So if you go to the next slide, Emma.
Sorry, 1 second.
Right, so I've got someone saying apneas. So that's true that you can get apneas, but that probably falls more under breathing than airway. So think about the airway in itself and what might you need, what could happen with the airway and what might you need to do around the airway. Those are that's much better slides than mine. Someone being on a speedboat, much more exciting. Right, there we go. So airways. So you're not necessarily going to have a, Nicholas, you're not necessarily going to have a malformation that's not necessarily there before. But if you think about a sick child, one of the first things that happens is they lose tone, and they may have some degree of neurological dysfunction that arises from either hypoxia or poor perfusion to the brain, and overall a reduced ability to maintain a safe airway. So it's more about the safety of the airway and maintaining a safe airway, and the reduced tone, much like as you have with NLS. You know, you talk about a term baby. A lot of the problem isn't due to obstruction, say, for example, with mucus or vernix or whatever. It's mostly due to tone-related issues. So the reduced tone might result in the child's airway becoming more floppy, the palate and tongue flopping back. And so what you may need to do to start off with might just be positioning, might just be to give some positive airways pressure. And then, of course, you may need to secure the airway with intubation. And as Zubair says, you may be at a risk of aspiration, vomiting, etc. So you may want to secure that airway against those kinds of things by intubating. But not every baby needs intubating. And certainly that sort of early sepsis phase, where before you know whether it's more severe sepsis, NEC, or some other problem like a cardiac problem, positive airways pressure might be a really good initial method to support the baby's airway and keep it open. So the airway was sort of an opening up kind of thing. If you move on, Emma, to B. And this is where is it Sabina, I think? Yes, Sabina's thing about apneas comes in. So this is a really nice graph, which I can't show you at the moment because I can't share my screen with you. But it shows you what happens with hypoxia and poor perfusion in babies at different gestations. So if you think about you and I, if we get hypoxic, the first thing we would do is feel free to pop a message. Pass out. So yeah, before you pass out, what would you try and do to stop yourself from passing out? Yes, exactly, Maduka. You would breathe faster, and most of us would breathe faster and hyperventilate until you reach a plateau where you just cannot breathe any faster. And then if you still can't overcome your hypoxia, then as Sarah says, you'd sort of pass out. A term baby would do something very similar, and certainly infants would do something very similar. But their ability to sort of hyperventilate is certainly going to be less than mine and yours. A term baby and a near-term baby actually doesn't reach that plateau. They breathe faster to start off with, and very rapidly reach the most that they can do, and then they actually start becoming, they start hypoventilating, which is what you tend to see in term babies who've got sepsis, is that hypoventilation and an increase in their CO2 may be one of the first things that you see. Preterm babies, interestingly, and certainly the more preterm you get, the response is a complete opposite. So they get hypoxic, they don't go into that hyperventilation phase. They go straight into sort of hypoventilating and being apneic. And so your preterm baby with NEC, for example, would often just go straight into having apneas. And that's why, again, apneas can often be an early sign of there being a problem. And that's that sort of immature response to hypoxia. Another thing, of course, is that hypoxia may come from the lungs. So you may have an infection, you may have reduced drive, etc. But hypoxia could also come because you've got reduced cardiac output. You're septic, your myocardium's a bit stunned. We'll come on to that in just a minute. But those things may make you put less blood into your lungs. You may have a PDA, etc. So the countermeasures for those are oxygen. So much the same as in adults, older children, you want to oxygenate, but you also want to ventilate, because actually, unlike with older people and adults and older children, hypercarbia could be an early problem. So you need to ventilate as well as oxygenate. And that ventilation may be by giving supportive positive airways pressure in milder illness. That might be adequate for an older baby that can still hyperventilate. But the more premature you are, and the more you're likely to have that immature response to hypoxia, you're more likely to need invasive ventilation. So before we go on to the next slide, what can happen in terms of the cardiovascular system? What are the things that you're likely to experience with a sick baby? And I'm not moving on to the next slide deliberately because I want to see some answers. Okay, so tachycardia, yep, but no extra points for that one though, because we've already been talking about that. Hypotension, okay, shock, poor perfusion, yep, mottling, poor perfusion. Good, so you've got a range of answers there. And I suppose that the thing to say is that what you're describing are signs that demonstrate to you that the heart is working less well. So tachycardia is a compensatory mechanism. Your heart, either for whatever reason, is either not being able to function very well or is underloaded. So it's trying to improve the cardiac output using tachycardia. Now bear in mind that babies have got a very limited ability to alter their cardiac output. They can't really change their stroke volume as much as you and I can. So the only real way they can improve their cardiac output is by tachycardia. That's why you get that sort of early response with tachycardia. Hypotension we'll come to in just a minute. So shock is an end stage of all of this. So there's a common ending which ends up in shock, which basically means you're not perfusing your organs, and that sort of fits in with the poor perfusion. And what Sabina says, delayed capillary refill is one of the signs that you've got poor perfusion. What are the other signs that might tell you that your perfusion is not as good as you think it might be, even if, for example, your capillary refill time might look okay? So, yeah, exactly, Sarah. So low cardiac output, and also looking at your respiratory response as well, and how well your brain is functioning with that. So let's look at hypotension for a minute. How do you define hypotension in a newborn? Okay, so Sarah says depends on gestation and age. I won't give Sarah any extra points for that because that's the answer for everything in neonates. Yes, Sarah, exactly. It's a non-committal answer. So anyone want to expand on what Sarah says? So what about gestation and age? So we've got mean less than 35. Mean blood pressure less than the gestation in weeks. Okay, good. Getting a bit more specific now. Yes, I've got another mean just less than gestational age. So Emma, if you skip the next slide and go on to the slide number 5. So the mean less than the gestational age or mean equal to gestational age is often used as being a sort of a rough rule of thumb for hypotension. The sad thing is that that's probably only true on day 0 at the time of birth or just immediately in the first sort of 6 to 8 hours. If you look at that graph, it shows you very nicely that actually over the first 2 to 3 days, the estimated mean blood pressure actually goes up quite significantly beyond the gestational age. And I think these are sort of the 10th centiles. So it's not that every baby born at 24 weeks will have a mean blood pressure of 24. Actually, 90% of them will have mean blood pressure that is greater than 24. It's only 10% that will be 24 or less. And actually, by the time you get to about 3 days, if you're a 23 to 24 weeker, you should be looking at a mean blood pressure of somewhere around 28. So my rough rule of thumb, if you're just looking at blood pressure, is to say that if you're more than a couple of days old, your mean blood pressure should be 5 above your gestational age. That should be your starting point. And at the very least, you should look at what the previous mean blood pressures were. And if they were above that 5+ gestational age, you shouldn't really allow it to drop by more than 10 or 15% before considering this baby to be hypotensive for themselves. And hypotension is actually a fairly poor indicator. Some of the other stuff that people have talked about so far, like the cold peripheries, the delayed capillary refill, the low urine output, the hypoventilation, etc. Those are probably all far better markers of perfusion. Because ultimately, the hypotension doesn't tell you anything more than the blood pressure has come down. What you really want to know is what is the cardiac output, and what effect does that have on the other organs? Because that's what you need to act on. Blood pressure is often used because it's a very easy marker, but it's really dependent on so many different factors that it's not a particularly great marker. So let's go back one slide, Emma. And so if we look at the cardiovascular side of things, the countermeasures are broadly talked about in terms of volume, improving oxygenation, and improving cardiac output. So let's talk about volume first. How much and what type of fluid would you give if the baby had evidence of poor cardiac output? So what Justina is saying, 10 mL per kilo of normal saline. We've got another 10 per kilo of saline. All right, there seems to be some consensus at the moment that it would be 10 per kilo of saline. When would you give that 10 per kilo of saline? Would you give it to any baby that's hypotensive? Okay, so Sarah says, if you're worried about cardiac stuff, if you're worried about fluid overload, what are there more poor perfusion? Okay, so volume is often the easiest thing to give because it's 10 per kilo of saline is about the fastest thing that the nurses can draw up. It's about the fastest thing that you can prescribe. And hopefully Sarah's got that easy cannula in from earlier, so you've got ready access to give the 10 per kilo of saline as well. The problem with saline and with fluid boluses in general is that unless you've got hypovolemia, it's unlikely to make a lasting difference to this child's cardiac output. And as both Sabira and Sarah have mentioned, if you've got a big PDA with fluid overload, if you've got a myocardium that's already stretched and dysfunctional, actually giving more fluid and filling it up even more isn't going to help improve your cardiac output. In fact, it could make things worse because this poor myocardium is already a bit stunned and not sure what to do and is not contracting particularly well. So if anything, you should do what Sabira's just mentioned there, which is if you're struggling with hypotension, poor perfusion, you're worried about the cardiac output, but you don't have clear evidence of hypovolemia, you should think about using inotropes earlier to improve your cardiac output. And in terms of fluid as well, 10 per kilo of saline is probably the easiest thing to give. But if you're hypotensive because you've lost blood because you've got DIC, or you've got DIC and you've got other evidence of bleeding elsewhere in the baby's body, then saline may not be the best thing to give. If you're only going to be able to give 10 or 20 mils per kilo of fluid, what you probably want to give are blood, FFP, and other sort of blood products that can help correct those abnormalities. Otherwise, you could potentially give the saline, then have to give 20 or 30 mils per kilo of other blood products, and then you've got this problem of fluid overload as well. So now that Sabira has mentioned inotropes, would everyone agree with her on dopamine, or would someone choose something different? Okay, while people are thinking, Sabira, can I ask you to just write down very briefly why you chose dopamine as the first inotrope? Yep, I completely agree with that. It's simple and safe, and actually can be given peripherally as well. So while you're struggling, it's a good option. And yes, Croydon Neonatal Unit in its entirety seems to be saying that dopamine has a practical advantage, and I completely agree with that as well. Now Sabira says there's a wide range of dosing to work with. So that is true, but that's probably true of all the inotropes. You can use ranges from 3 to 20. But dopamine doesn't work in exactly the same way at all the different dose ranges. And actually it works slightly differently at different dose ranges. So we'll come on to that in a minute. Yep, covers renal, kind of, Sabira says. Yep, that's at the lower end of the ranges. So I think the consensus appears to be, given that no one else wants to say anything against what Sabira said, that dopamine is the first one that you would use. And in practical reality, that's probably true. The benefit of dopamine in the lower doses, so somewhere between 3 and maybe 5 to maybe 10, but I think by the time you get to 10, you're starting to see the vasoconstrictive effects. But certainly in the lower doses, it improves your renal perfusion, it improves your myocardial function. The problem with dopamine, though, is that once you start going over, say, 5, certainly about 10, you start to see its vasoconstrictive effects. Now that can be beneficial. Vasoconstriction would certainly improve your blood pressure because it provides peripheral vasoconstriction, so your heart's having to work harder against it and raises your blood pressure. But that doesn't necessarily improve your cardiac output. And what you really want here is to improve your cardiac output. If you've got a baby whose myocardium is already struggling, and you actually increase the peripheral vascular resistance, you can actually push that heart into even worsening failure. So you have to be really careful with things like dopamine about the doses. But yes, it can be given peripherally, and it can be a reasonably good initial one to use. So let's say you've used that initial little bit of dopamine, but this baby is still hypotensive. and you still got evidence of poor perfusion, urine output is low, base excess is high, lactate is going up, what would then determine your second inotrope? And any choice of a second inotrope. Okay, good, Nicholas. The cause of the shock, that's really important. And Sarah says you think about the peripheral vascular resistance. Absolutely. So Sarah, do you want to expand on what you said about the peripheral vascular resistance? And yes, Croydon says high suspicion of cardiac or not. Absolutely, that would also make a difference. Now, for the moment, I'm probably not going to talk about cardiac diseases as a cause for the shock, only because that's a fairly wide topic on its own. We'll probably stick to sepsis, NEC, and those sort of immediately reversible kinds of things. So Sarah says if you're concerned about peripheral perfusion, targeting peripheral vascular resistance might cause further issues, but if it's more warm shock, absolutely. So that's a really good answer, Sarah. So if you're thinking that you've got gram-negative sepsis, whether it's NEC or just plain gram-negative sepsis without necessarily NEC, and you've got significant vasodilatation, which is causing your hypotension and poor perfusion to your internal organs, then absolutely an inotrope that might cause more vasoconstriction might be a really good inotrope to try and use. Because what you really want to do is to improve that peripheral vascular resistance and improve your cardiac output and perfusion to your critical organs that way. So if that was the case, what would be your preferred inotrope for that? And I'm using the word inotrope in the broadest sense. Yeah, so Nicholas says noradrenaline, severe norepinephrine, same thing. Yes, exactly. So noradrenaline's got a very, very specific range of action. It works particularly well as a vasoconstrictor. So it's quite a good one to use in that warm shock scenario. Outside of that warm shock scenario, you have to be really careful with your use of noradrenaline for the reasons I mentioned earlier about the effects on your myocardium. And if you're using NORAD, the dose ranges, people tend to use slightly different ranges. We tend to use between 0.1 and at most 0.5 micrograms per kilogram per minute. Occasionally, in absolute desperation, people have used doses going even up to about 1. My general impression has been that once you start going over about 0.5, you may keep someone alive, but it's very likely you're not going to cure their problem, and you may just be delaying death for a day or two at best. The effect on other organs, perfusion, the kidneys, you tend to find problems later on. So typical ranges are somewhere between sort of 0.1 and 0.5. And again, at 0.1, the way most people make it up, at least certainly we make it up, it's made up as a solution that runs at 0.1 is about 0.1 mils per hour. And from a practical perspective, by this point, you're hopefully going to have central lines. And one of the problems is that by the time you've got multiple different infusions running, getting the actual dosing to leave the pump or the initial line and get into the actual central line into which the fluids are running can take a bit of time. So sometimes you might have to run it at sort of 0.2, 0.3 to start off with, and then back off once you start seeing it hitting the system. So noradrenaline's a good one for that kind of scenario. Let's say it's more a case of a myocardium that's not functioning particularly well. You may actually already have some degree of vasoconstriction because you've used your dopamine. Is there any inotrope that people tend to like using in neonates, which might be useful in that scenario? Yes, so dobutamine. Dopamine and dobutamine are the sort of classic neonatal inotropes. I think we've moved away from just starting dopamine, dobutamine randomly to thinking a little bit more about which one we're going to be using. But dobutamine actually tends to work quite well. Only problem with dobutamine is that it does tend to cause a bit of a tachycardia. And if you're already tachycardic and you increase your tachycardia further, you go beyond where it becomes useful from a cardiac output perspective to not giving enough time in diastole for the heart to fill. And further tachycardia can actually make things worse. But dobutamine, certainly in low doses, can be quite a good inotrope. It works really well in terms of myocardial contractility. It actually drops your systemic vascular resistance a little bit. And so if you've got a lot of vasoconstriction from your other drugs, it can be quite helpful from that perspective, just to help improve your cardiac output by offloading the heart a little bit as well. And very similar to dopamine, the dose range is somewhere between sort of 5 and 20. And again, with most of the inotropes, if you sort of get to about 10 or so and you're not getting the effect that you need, going above that to 20 doesn't generally tend to improve cardiac output very much, but it does tend to increase your side effects. So by the time you get to about 10 or so, you need to start thinking about adding something else on. Let's say your baby with gram-negative sepsis is on a bit of dopamine, a bit of dobutamine, and you might have started some norepinephrine as well. It's not necessarily an inotrope, but it's a drug that can be quite useful, especially in preterm babies in sepsis. And people are starting to use it a little bit more frequently than we used to use it before. So Sabira says IVIG. I think IVIG, the jury has probably come back on that one now and said it probably doesn't help. And certainly doesn't help in an acute situation. It may, if it was going to help, helps more with that sort of inflammatory cascade later on. Yes, Philippa, and I think Sam, yes, hydrocortisone. Mm-hmm. Exactly. So hydrocortisone may work by, well, I suppose like with most functions of steroids, no one's entirely certain exactly how it works. But the general feeling is that it probably improves your receptor responsiveness to the catecholamines that you're giving, so your adrenaline, noradrenaline, etc. But it certainly seems to have a positive effect on both blood pressure and cardiac output by possibly improving your myocardial contractility as well. The other reason why hydrocortisone may be particularly helpful is that there's a greater understanding that sick newborns, just like they do with their breathing, just switch off everything, often switch off or don't increase their stress response and produce more hydrocortisone. So giving hydrocortisone can be quite helpful in this situation. And certainly we do seem to be using it more frequently quite early on, and it does tend to sort of work reasonably well. I haven't mentioned adrenaline a lot. Adrenaline certainly in the high is very similar to dopamine in the higher doses. It's quite good in terms of improving your myocardial contractility, but it has this problem of increasing systemic vascular resistance as well. But certainly, if you're starting to have to use higher doses of dopamine to have that effect, you're probably better off just switching across to adrenaline. So we've talked a little bit about fluid. We've talked about the inotropes. It's sort of a whiz bang through the inotropes, but there's lots of resources you can find online that talk about which inotrope and when. I think the main thing to remember is it's not as simple as we'll just give dopamine and dobutamine. You just have to think a little bit more, and don't forget things like hydrocortisone. So let's move away from the C. Mm-hmm. And then I've not quite gone all the way to Z. I'm sure you'll be pleased to hear. I've sort of stopped at I. The D is sort of the disability, and this is more about detecting and preventing rather than doing something acutely. So it's just to remember that that improving your cardiac output is your aim rather than just improving your hypotension. And the reason for that is that you want to try and reduce the disability. You want to make sure your perfusion to your brain continues to be good. You want to make sure you're doing all the things that you need to try and improve cerebral perfusion and oxygenation. So making sure your oxygen levels are adequate, making sure you're not becoming hypocarbic. Because some of these babies, actually, their lungs may be okay, and it can be very easy with ventilation to make them, to over-ventilate them. So just being really careful with that. Exposure, the reason why I put that there is we know that babies who are septic or babies who are unwell, again, much like their breathing and their blood pressure, they're just very poor at maintaining their temperature. And it's very easy for you to make them hypothermic, especially when there's often a lot of handling involved, intubating, putting lines in, etc. And part of that is also just when you're putting lines in, being really careful about the cleaning fluids. Don't let babies lie on soaked, wet sheets while you're doing this. it's the kind of stuff that's very easy to forget because you're too busy trying to look at the sort of the immediately life-threatening things. And then fluids, we've talked a little bit about the type of fluid, the saline versus blood products. There's very little evidence for using anything other than either blood products or saline. Colloids, more weird and wonderful fluids other than saline. None of those things have actually been shown to be particularly beneficial. In fact, some of the colloids that they would use in adults, albumin, for example, in some studies have been shown to be potentially harmful as well. So stick with this straightforward stuff. And then just to think early on about how you might actually give all of these fluids and drugs. So one of the things that often people find is that babies start to get a bit unwell, and they're properly sick by the time someone's thinking about putting lines in. And that's often the most difficult time to get those lines in because your baby's shut down, they're hypovolemic, they're hypotensive, they're not tolerating handling particularly well. So early on, start thinking, is this a child I might need central access on? And even if you can just get a 1 French line in to get your inotropes in, and you do that early on, if in 24 hours time you find actually the baby is not that sick and you don't need that line, it's much easier to take off that line at that point rather than in 6 hours time trying to put a line into a very sick baby. So early lines. Sugar, that sort of falls into the nutrition side of things. Simply to say, don't forget nutrition. So if you can continue to give a degree of PN, try and give some because you're still going to need some of that. But also don't forget all your hypo and your hyper. So trying to correct your electrolytes, trying to correct your calcium. Without, if you've got hypocalcemia, for example, your inotropes are not going to work particularly well. Your heart's not going to function particularly well. And when you get really sick and septic in your third spacing, all of these numbers can go off quite significantly. And then lastly, there's the infection and choice of antibiotics. I think I heard Sabrina talking earlier about triple antibiotics. I think it's very much about understanding your own unit's antibiotic policies. Sometimes just going for a numbers, thinking that you need to have 3 antibiotics isn't always helpful. So for example, one of the common things that I see a lot is children being started on tazocin and vancomycin and then having metronidazole added in as well. There's very little metronidazole will do that tazocin and vancomycin and certainly a stat dose of gentamicin doesn't cover. But what you are doing, as Claude and Nick, you said earlier, is making the nurses' lives more difficult. And where you're already struggling with access, trying to find another piece of access to try and give metronidazole 3 times a day as an infusion, it just makes it more challenging as well. So especially if you've got challenges with access, choose your antibiotics wisely. And you may find that actually you have to think about which antibiotic you use to try and minimize the number of antibiotics you're using as well. So I'm going to stop there because it's sort of 10:02, and I know Sarah's got some MCQs for everyone. I'm happy to answer any questions that you might have for the next minute or so.
If anyone's got questions, pop them in the chat, or you can take yourself off mute. I'm just gonna get the quiz up and running. Emma, let me see if I can share my screen. Oh, I think I can.
Thank you very much, Dr. Francis. That was fantastic.
Yeah, that was. Okay, can you guys see my webpage?
Yes, we can.
Okay, fab. All right, so I'm just going to wait for the quiz to load. The quiz is semi-anonymous, so everyone is allowed to give themselves a nickname. Perhaps in keeping with this week's theme, maybe something neonates related, maybe your favorite bit of neonatal equipment. So if you're using your mobile phones, or people like Croydon, if you're logged in together, just get on the desktop, go to www.kahoot.it, that's KAHOOT.it, and give yourself a nickname. It can also be your own name. And CJ, if you're sticking around, we had a lot of fun playing Beat the Consultant at the quiz last time. While you all get logged in, the way it works, there's only 5 questions, so it'll be very quick. Each question comes with a case history that will come up, and you then have 30 seconds to answer the question. You'll have 4 options. The questions are all essentially what is wrong with this baby. There are points for answering the question correctly, but there are also points for how quickly you answer the question. The idea is to get you ready for your exams, especially the written exams, get you into answering questions quickly and accurately, and just kind of put some of this knowledge from this session into use. Okay, great. We've got some fantastic neonate related nicknames here. Basic success, it's niche, but that's great. So there's 41 people in the chat, so we will give it maybe another minute and see how many people want to join in with the quiz. The more the merrier. Safety in numbers as well. Curacao, very important. Interested that there's a Gelco but no Neoflon there. I think that's very telling. Okay. All right, 20 seconds. All right, let's begin. So, first question, here we go. Going to come up in 1 second. Okay, so what is the most likely diagnosis for this baby? You've got a 28-weeker infant, ventilated for 6 days, now day 25 on vapotherm, full enteral feeds, increasing respiratory rate, apneas, febrile, cold hands and feet, good air entry, abdomen with no bowel sound. All right, you've got 10 seconds left to commit to an answer. Oh, make sure you get the answer in. There's no negative marking, just like in the exam. Very good. Okay, so a couple of people thought GBS sepsis. I think that's a good thought. However, this baby is a little bit older now, so perhaps a bit less likely. The big flag in there was the distended abdomen and the bowel sounds, which meant the neck was the most likely one here. Well done. Let's try the next one. See where we are at the moment. Okay, RL is on top just about, but it's a close race so far. So what would you check first in this baby? This is a large term baby, and this is an X-ray at 2 hours of life after a difficult vaginal delivery. Just like in your written exams, this is a small, poorly reproduced X-ray that I've taken from Google. If you are used to taking the MRCP written exam, you will know about the science and you will be allowed them when you get to your real exam. All right, 5 seconds to go, commit to something. Brilliant. Okay, I think everyone actually answered there. Yeah, I would say in this one, probably distal pulse is the most immediately concerning feature, because if you haven't got one of those, then you need to manage this pretty sharpish. Fracture of a clavicle, obviously worth looking at, but at that X-ray, it didn't really look like there was any clear fracture there. Moro reflex is going to tell you a bit about the nerves in the arm, but again, the distal pulse is probably the more crucial time-sensitive aspect. And blood sugar, I mean, it's always good to know, isn't it? But I kind of just threw it in there because it's just a big baby, really. That might be a bit hypoglycemic after a long delivery. Good job. Where is the leaderboard here? Okay, DeBoss is in the lead, and Pat is still in there pretty high up. All right, 3 more questions to go. We're back to what is the most likely diagnosis. It's another 28-weeker who's collapsed at 3 weeks. They're on NCPAP and they are having TPN, poorly perfused, tachycardic, hypotensive, no murmur but quiet heart sounds, mixed metabolic and respiratory acidosis, and your chest X-ray shows a massively enlarged cardiac shadow and normal lung field. So we've got some classic neonatal nightmares here. Get an answer in, just 5 seconds to go. Press something. Okay, yeah, well done to those of you who said cardiac tamponade. The idea here is that that long line has gone awry, and that TPN is then going into the space around the heart. The key clues in there were the muffled heart sounds and the fact that the heart was enlarged but the lung fields were normal, so that made your tension pneumothorax less likely. It could always be sepsis, that's a fair shout, and this could be congenital heart disease, but given that, again, this is a slightly older neonate with a sudden collapse, that made the tamponade more likely in this scenario. So here's our leaderboard. Oh, it's all happening. DeBoss is still in the lead, but we've got a late entry into the top 4 from Posey. Still everything to play for. Let's go on to question number 4. Penultimate question. Term baby born in good condition, mom's O negative, jaundiced at 12 hours. They start on phototherapy, but the bilirubin continues to rise and they've had an exchange transfusion. What do you think is the cause of the jaundice here? Is it G6PD deficiency, rhesus disease, ABO disease, or hereditary spherocytosis? Mom's O negative, baby's A positive, the DAP's negative. What could it be? 1 second to go. Fantastic. Yeah, so this is a little bit of a tricky question, but these questions about jaundice do actually seem to come up quite frequently in the exams. So any one of these things could give you jaundice. It seems like most people were torn between the rhesus incompatibility and the ABO incompatibility, obviously because you did have a difference in the rhesus positivity and also the ABO group between baby and mum. The reason that these questions tend to want you to go for ABO incompatibility is that they will tell you something about the jaundice that doesn't respond particularly well to phototherapy, and that ends up resulting in an exchange transfusion, particularly jaundice that rises really, really rapidly straight after birth. So look out for those kind of features in the history. They're fairly typical for these exam questions. All right, where are we before the final question? Okay, Pat has taken the lead, but is only ahead by 7 points. Okay, very exciting. Let's have a look at the last question for today. What is the most likely diagnosis for this baby? Term neonate with respiratory stress shortly after birth. Diminished air sounds bilaterally, but particularly on the left. The apex beat is on the right. What's going on? No murmurs. Pulses are all fine. Abdominal exam seems normal. This is their chest and most of the abdominal X-ray. You've got 10 seconds left to try and win this week's case exchange. Let me know what you think is wrong here. It's gone from a mix of. Fantastic. Yes. Okay. This is the classic congenital diaphragmatic hernia. Clues here. Oh, I didn't know that I could make the picture come back up again. That you've got that apex beat on the right, which is quite suspicious for things being arranged a bit differently in this baby. And if you look at this X-ray, you can see some bowel that's come up into the chest there, and a cardiac shadow on the right. So, without any further ado, let's see who's won this week. In third place, we've got RL, very good, very good. Second place, DeBoss, fantastic. And number 1 is Pat. Very well done, everyone. Yeah, very good indeed. If you've got most of those questions right, you have a fantastic chance at your exams. So thank you very much, everyone, for coming along. I hope you enjoyed this week's case exchange. Thank you so much to Sabina and also to Sijo for presenting this week. And we will see you next month at the beginning of February. We're going to be swapping case exchange to a Tuesday from next month. And we are going to be hearing from one of our lovely SHOs who's going to present a case for us. Then the eminent Dr. Gomez will be teaching us as well, and we will have yet another quiz. So we'll have a lovely new year, and we will see you very soon. Also, before we go, just going to say that we do have a feedback form. It's really, really helpful to us if you put it in. I'm popping it in the chat now. And this is really, really helpful, A, to make sure that we can continue to get the funding to use the software like GoToMeet and provide teaching, and also so that we can kind of guide future sessions according to what you guys want. That's it from me.
Just to reiterate, if anyone would like to speak, please do email either myself or Sarah. I'm Emma Russell-Jones, she's Sarah Sturrock, and we're around. I'm based at Croydon, Sarah's at George's, and yeah, we'd love to have some speakers.
Yes, and someone's just asking, it is neurology next time, and neurology is very difficult and confusing. I'm sure about coming to that one. And the next day, Emma, is it the 2nd or the 9th?
Sorry?
The next month's session.
The next month's
The
session.
date for next month's session. Do we do
It's on the 2nd of February.
Yeah, so it's still the first week of the month, but it's just the Tuesday, not the Monday. All right. Thanks very much, everyone. Fill out your feedback forms. Bye.
This conference will now be recorded.